Hello everyone. Today we are going to talk about chemical plaque control. What it is, the agents we use, and how they help in preventing periodontal disease. This is Dr. Sugita, Department of Periodontics. Introduction. Plaque control is removal of dental plaque on regular basis and the prevention of its accumulation on the teeth and adjacent gingival surfaces. So that is, it means regularly removing the dental plaque and preventing its buildup on the teeth and gums. So it forms through bacterial attachment followed by bacterial growth and division. So the chemicals helps by preventing the bacteria from sticking and by slowing or stopping their multiplication. Mechanism of action of the chemical agents. An ideal anti-plaque agent should reduce harmful bacteria and gingivitis, not promote resistant bacteria, have substantivity, meaning it stays active in the mouth and be safe for oral tissues. So there are two basic processes of plaque formation. One is bacterial attachment and bacterial proliferation. So the chemicals will act by preventing the bacterial attachment and steps on slow bacterial proliferation. So these are the ideal properties of anti-plaque agents. Coming on to the generations of anti-plaque agents, the first generation agents reduce plaque by 20 to 50% but have no substantivity and need frequent use. The second generation agents like chlorhexidine have antibacterial action and high substantivity. So it works up to 18 hours. Third generation agents selectively target the specific bacteria or their products. So enzymes that alter the polysaccharides involved in plaque formation. Classification of anti-plaque agents. So anti-plaque agents can be enzymes like first group and second group, phenolic compounds like thymol, listerin, phenol, eucalyptol, menthol, quaternary ammonium compounds like benzyl conium chloride, cetylpyridium chloride, fluorides like sodium and stannous fluoride, oxygenating agents like hydrogen peroxide and sodium peroxide, bis-biguanides like chlorhexidine, alexidine, bispyridines like octinidine, metallic salts like zinc, tin, copper, silver, mercury, herbal extracts like neem, acacia, sanguinarine, amine alcohols like octophenol and delmophenol, and miscellaneous like sodium lauryl sulfite. So coming on to the phenolic compounds, phenols known as it is known since 1867 and it works by protein denaturation and damaging the bacterial cell membranes. So this is a commercial example for a phenolic compound is listerin. It can reduce the plaque but often needs frequent use. Coming on to the quaternary ammonium compounds. So examples are benzalconium chloride and cetylpyridinium chloride. So they moderately reduce the plaque but are less effective due to quick loss from the oral surfaces. Coming on to the triclosan. So it is a phenol derivative recently being included in the mouth rinses and toothpaste in order to reduce the plaque formation. Synthetic, non-ionic and is used as antimicrobial agent also. So triclosan, it has a broad spectrum of activity. It is a broad spectrum antibacterial agent which is found in some toothpaste and mouth rinses. Okay, so it can reduce the plaque thickness, slow maturation and also has anti-inflammatory effects. Coming on to the fluorides. So fluorides, they have effect on caries prevention. It is well known. Okay, so besides preventing the caries, stannous fluoride can inhibit the bacterial enzymes and has better anti-plaque activity than sodium fluoride in short-term studies. Coming on to the oxygenating agents, oxygenating solutions like hydrogen peroxide. So it is an oxidizing agent that liberates nascent oxygen which oxidizes necrotic matter and bacteria. Catalase present in the tissue speeds the decomposition resulting in foaming which helps in loosening and removing of slough. Hydrogen peroxide has poor penetrability. So hydrogen peroxide will release oxygen helping to loosen and remove the debris and reduce the anaerobic bacteria. However, its effect is short-lived and penetration is limited. See, it is the action on plaque. It reduces the thickness of the plaque and also its protein and carbohydrate content. Reduction in the number of anaerobic bacteria as well as actinomycetes after 21 days of exposure with triclosan delays the maturation of the plaque. So these are the effect on gingivitis, like it is more obvious than its effect on the plaque. The best effect is seen from 3 to 6 months after initiation of triclosan use. Being a lipid soluble and hence known to be able to penetrate the human skin, it could be suggested that triclosan has an anti-inflammatory effect. Coming on to chlorhexidine. So chlorhexidine is available in digluconate, acetate and hydrochloride forms in rinses, gels, sprays, varnishes and chewing gum. So it's highly effective, but it can cause side effects like staining, taste changes, calculus buildup and mucosal irritation. Okay. So mechanism of action, that is high concentration and low concentration. So see, these are the various side effects. So, so in higher concentration, there occurs the bactericidal action, and if for a low concentration, there occurs the bacteriostatic effect. So these are the other side effects that is associated with chlorhexidine. There will be painful disc formation also. Unilateral or bilateral parotid gland swelling is also seen. So this is the brown staining of teeth. Mucosal erosions are seen. The formulations that are used were 0.2, 0.1 and 0.12. See, gels like 0.1% chlorhexidine gel is available, delivered on toothbrush or trays. 0.2 and 0.12 chlorhexidine gel are also available. Sprays in the concentration of 0.1 and 0.2 and 0.2% useful for physically and mentally handicapped patients. Coming on to the toothpaste. So it is difficult to formulate. Varnish is used for prophylaxis against root caries, and chewing gum 20 mg of chlorhexidine acetate per day for 5 days is given. Clinical uses, so it is used as an adjunct to oral hygiene and professional prophylaxis, post-surgical therapy in patients with jaw fixation, in physically and mentally handicapped patients, aerosol reduction and treatment of oral candidiasis. So coming on to alexidine, so it is also similar to chlorhexidine but with no major advantage. Okay, so octinidine, it can reduce plaque and gingivitis but may cause mild staining and taste changes. It can be used twice or thrice daily, showed reduction in the plaque and gingivitis. Some experience mucosal irritation also. Minor taste alterations are also seen. Coming on to the metal ions. So it is established that some metal ions have anti-plaque capacity. So the metal ions commonly examined are stannous fluoride, cuprous and zinc ions. So ions like these have anti-plaque effects. Often they are used in combination with other agents for better results. Okay, so the volatile sulfur compounds that results in tissue damage is inhibited by these zinc, stannous and cuprous ions, mainly in case of halitosis. Coming on to the quaternary ammonium compounds. So in quaternary ammonium compounds like benzylconium and cetylpyridinium, moderate plaque inhibitory activity is seen. They are less effective because these compounds are rapidly dissolved from the oral mucosa. So substantivity is not there. Coming on to the neem and acacia. So it is a complex mixture of calcium, magnesium and potassium salts which is traditionally used for plaque control. So the other examples are plaque rinse, which helps loosen the plaque but may cause staining and altered taste. It is an antibacterial detergent. The disadvantage is that slight anesthesia to soft tissues, bitter taste and light brown staining of teeth is not accepted by the ADA. So coming on to the hexidine and povidone iodine and all. So they have short substantivity and can cause irritation at high concentration. Povidone iodine has limited anti-plaque effects and may cause allergic reactions in sensitive individuals. So coming on to delmophenol, see the povidone iodine, delmophenol gel. See, delmophenol interferes with plaque matrix formation and bacterial adherence. Okay, so morpholinoethanol derivative, it inhibits the plaque growth and reduces gingivitis. It inhibits the salivary bacteria for only 30 minutes. It interferes with plaque matrix formation and reduction of the bacterial adherence. So these are the adverse effects of delmophenol like transitory numbness of tongue, tooth and tongue staining, taste disturbance, mucosal erosions and soreness. Coming on to the saliflor. See, it is a salicylate which has both antibacterial and anti-inflammatory properties. Recently, a combination of saliflor and polyvinyl methyl ether malic acid have been investigated in vitro. Okay, so Saliflor will combine the antibacterial and anti-inflammatory action. Sometimes it is used with polymer carriers. Natural products like sanguinarine, so it is from the bloodroot plant. It inhibits the plaque bacteria and works synergistically with zinc. Okay, but propolis from bees also has antibacterial and anti-inflammatory properties. So it mainly contains flavones, flavanones and flavanols, antiseptic, anti-inflammatory, antimycotic and bacteriostatic agent it is. So next is disclosing agents. So disclosing agents, these agents stain the plaque to make it visible for better removal. Examples include iodine solutions like Bismarck brown, erythrocin, fast green and fluorescent dyes. So erythrocin, concentrate for application by rinsing. FDC red number 3, number 28 to 6 grams, water 100 ml. For direct topical applications, erythrocin 0.8 gram, water 100 ml, alcohol 10 ml and oil of peppermint 2 drops. So fast green 3 to 5% or 2.5%. Fluorescence, FDC yellow number 8, used with a special UV light source to make the agent visible. So what are the local and the systemic side effects? So the local effects may include epithelial peeling, mucosal lesions and staining. A rare systemic effect include allergic reactions or triggering certain metabolic disorders in sensitive individuals. So like systemic effects, erythema multiforme caused by mouthwash with iodine. Coming on to oral irrigation devices. So oral irrigators deliver a pulsating water stream to remove the debris and bacteria. So they can be used supragingivally or subgingivally as an adjunct to brushing and flossing. Okay, so irrigation is targeted application of pulsated stream of water or other irrigants for therapeutic purpose. Oral irrigation is an adjunctive method for arrest and control of gingival infections. So what are the rationale of irrigation? So the biological rationale for supragingival and subgingival irrigation is to non-specifically reduce the microbial deposits that induces periodontal diseases. The primary objective is supragingival irrigation is to flush away the bacteria coronal to the gingival margin, thereby diminishing the potential of developing gingivitis. Subgingival irrigation is to reduce the pocket microflora in an effort to prevent initiation and progression of periodontitis. So oral irrigation is again done supragingivally. This helps flush away the bacteria above the gum line. It reduces the plaque toxins and toxic changes bacterial cell structure, making the plaque easier to remove. Subgingival irrigation, it was introduced in 1982. So subgingival irrigation targets bacteria which is left behind after scaling, helping reduce the risk of disease progression. So for supragingival, it is a mechanism. Dilution or removal of bacterial toxins interferes with plaque maturation, so loosely attached plaque is washed away. Irrigation will change the morphology of the bacteria so that they appear as cells with ruptured membrane. It reduces Prevotella intermediate, spirochetes and motile rods. See, subgingival irrigation was introduced by Newman. Microorganisms left behind during mechanical debridement will be removed by subgingival irrigation. So this is a subgingival irrigation procedure. So agents used for supragingival and subgingival are chlorhexidine, hydrogen peroxide, water, saline, sanguinarine, stannous fluoride, povidone iodine and tetrakiss-potassium peroxydiphosphate. Okay. So next is local application of these agents. So agents like chlorhexidine can be applied locally with syringes, gels, slow release strips or varnishes for prolonged effect, especially in high risk patients. The case technique. So the case technique involves a mixture of salt, baking soda and hydrogen peroxide applied gingivally followed by irrigation with povidone iodine to reduce the bacteria. So conclusion, chemical plaque control is a valuable adjunct to mechanical cleaning, especially in patients unable to maintain a full plaque control on their own. So while agents like chlorhexidines are gold standard for chemical control, each comes with benefits as well as limitations, right? So the right choice depends on the patient need, risk factors and tolerance. But remember, no chemical can replace the fundamentals of good brushing and flossing. So they work best as a part of complete plaque control program. Thank you.